You have told your doctor you are tired, maybe more than once. Maybe you have said it at every appointment for 2 years. And every time they check your blood work, they look at the numbers and they tell you everything looks fine. Or they tell you it is your age. Or they give you a leaflet about sleep hygiene and send you home. And you leave feeling like you are somehow not being believed. I am here to tell you, you are not imagining it, and it is almost certainly not your age. There are 4 specific, measurable, correctable conditions that cause the kind of exhaustion you are describing. Conditions that are extraordinarily common in people over 60, and conditions that are missed, undertested, and undertreated in routine medical appointments every single day. To walk you through all 4, not in general terms. Specifically, the mechanism, the test, the name to ask your doctor, the food or action that begins to address it, because fatigue at 60 is not something to accept. It is something to investigate. Before we go through each one, I want to tell you something that took me years of clinical practice to fully appreciate. Fatigue is one of the most common complaints in medicine, and it is one of the least thoroughly investigated. In a typical 12-minute appointment, if a patient says they are tired, a doctor will check hemoglobin for anemia, check TSH for thyroid function, maybe check vitamin D. If those come back within the reference range, the conversation ends there. But here is what that misses. Normal on a standard blood test is not the same as optimal for your body. Reference ranges are built from population averages. Your body may function best at a level the test calls normal, but that is, for you, meaningfully below where it needs to be. And some of the most significant causes of exhaustion after 60 do not show up on a standard panel at all. That is what today is about. The 4 things that are almost certainly not on your doctor's checklist. Cause number 1, subclinical hypothyroidism. Your thyroid is a small gland at the base of your throat. It produces hormones that regulate your metabolism, the speed at which every cell in your body converts fuel into energy. When thyroid function drops, everything slows. Your thoughts, your digestion, your energy production, your body temperature, your mood. Most doctors test for this by measuring TSH, thyroid stimulating hormone. When TSH is elevated, but T4 is still within the normal range, the diagnosis is subclinical hypothyroidism. Subclinical, below the clinical threshold, meaning real, measurable, and usually untreated. How common is it? The Cardiovascular Health Study, one of the largest long-running studies of adults over 65 in the United States, found subclinical hypothyroidism in 15% of participants. 15%, 1 in 6 people over 65. And a separate ERIC study analysis, following over 5,000 Americans aged 65 and older, found that nearly 6% had untreated subclinical hypothyroidism on top of those already being treated for thyroid conditions, meaning their thyroid had deteriorated further and nobody had noticed. I want to tell you about a patient I will call Helen, 66 years old, former librarian. Meticulous, calm, precise. She came to me saying she felt as though her body was running through mud. Not tired in the way you feel after a bad night of sleep, tired in a way that did not lift. She would wake at 8, rest until noon, and feel as if she had been awake for 16 hours already. Her previous tests had been flagged as normal. Her TSH was 4.8, within the standard reference range of 0.4 to 4.5 in most labs. Almost every doctor would have stopped there. I ordered a full thyroid panel, TSH, free T3, free T4, thyroid antibodies. T3, the active thyroid hormone her cells actually use, was at the very bottom of the reference range. Her antibodies suggested early Hashimoto's disease. Her thyroid was working, but it was working very hard to produce very little. We worked together on her diet, added selenium-rich foods, addressed her stress. Her specialist eventually agreed to a trial of low-dose thyroid support. 8 weeks later, Helen sent me a note. I feel like someone turned the lights back on. 3 words that described what no blood test had ever captured. Warning signs of subclinical hypothyroidism, fatigue that sleep does not fix, feeling cold in rooms where nobody else is, unexplained weight gain despite no change in diet, dry skin, thinning hair at the outer edge of your eyebrows. That specific detail, the outer third, is a classic clinical marker, constipation, and a mental slowness that feels like thinking through fog. What to ask your doctor, not just TSH, request a full thyroid panel, including free T3, free T4, and thyroid peroxidase antibodies. A TSH alone, especially at the high end of the reference range, does not tell the full story. What to eat? Brazil nuts. 2 Brazil nuts per day provides approximately 90 micrograms of selenium, the mineral your thyroid uses to convert inactive T4 into the active T3 your cells can actually use. 2 nuts. Put them in a small dish next to your morning coffee. You will never have to think about it again. Now, cause number 2. And this one will surprise you because the number I am about to give you is one that most people and many doctors have never seen. Cause number 2, undiagnosed obstructive sleep apnea. A 2024 systematic review estimated that 83.7 million adults in the United States are living with obstructive sleep apnea. Of those, nearly 80% are undiagnosed. 80%. A 2024 review published in the Journal of Clinical Medicine found that 60% of men and 35% of women over the age of 60 exhibit at least moderate sleep apnea on formal sleep testing. Sleep apnea is not just loud snoring. It is a condition in which your airway partially or fully collapses dozens, sometimes hundreds of times per night. Each collapse triggers your brain to wake for a fraction of a second to restart breathing. You never know it is happening. You never fully enter deep sleep. And deep sleep is where your body does almost everything that matters, repairs muscle, clears metabolic waste from the brain, regulates cortisol, consolidates memory, restores energy. Without deep sleep, no amount of time in bed will make you feel rested, because you are not resting. You are suffocating slowly, repeatedly, while your body fires emergency responses all night to keep you alive. And in the morning, you wake exhausted, and your doctor tells you to work on your sleep hygiene. The reason sleep apnea is so often missed after 60 is that the classic presentation, loud snoring, gasping, witnessed pauses in breathing, becomes less obvious with age. Older adults are more likely to report insomnia symptoms than textbook apnea signs, and researchers have noted that older adults are more stoic about their symptoms. They accept poor sleep as an inevitable part of getting older. It is not. Warning signs specific to seniors. Waking unrefreshed regardless of how many hours you slept, falling asleep involuntarily during the day. Not just feeling drowsy, actually dropping off. Morning headaches that clear by midday. Waking to use the bathroom more than twice a night, difficulty concentrating, and mood changes that appeared without a clear reason. What to ask your doctor? Request a sleep study referral specifically. There are now validated home sleep testing devices that diagnose sleep apnea without spending a night in a laboratory. This is not a lifestyle inconvenience, it is a medical condition, and it has effective treatment. What to do now? Sleep on your side rather than your back. It is the single most evidence-backed positional change for reducing apnea events. Even mild elevation of the head of your bed, 10 to 15 degrees, has been shown in clinical studies to reduce the frequency of airway collapse during sleep. Now, cause number 3. You will have heard of this one, but I want you to set aside what you think you know about it for the next 2 minutes. Because the most important thing about this nutrient and fatigue is not whether your test says you are deficient. It is whether your level is optimal. And those two things can look identical on a standard result. Because number 3, functional vitamin D insufficiency. The word functional matters. Hold on to it. You may have had your vitamin D tested. Your doctor may have told you it was fine. And you may still be operating well below the level your body needs to produce energy, maintain muscle strength, and protect your brain. Here is why. The standard measures 25-hydroxyvitamin D. Most labs in the United States define deficiency as below 20 nanograms per milliliter, so anything above 20 gets reported as normal. But the Endocrine Society, one of the most authoritative bodies in metabolic medicine, recommends a preferred range of 40 to 60 nanograms per milliliter. Someone testing at 22 nanograms per milliliter will be told they are fine. They may be at less than half the level the Endocrine Society considers optimal. That gap is not theoretical. A review published in the European Journal of Applied Physiology found that studies on vitamin D and health outcomes consistently pointed to optimal concentrations in the range of 40 to 60 nanograms per milliliter, not 20, which is merely the threshold for avoiding deficiency. And the mechanism connecting vitamin D to fatigue is direct and documented. Vitamin D receptors sit on the inner membrane of your mitochondria, the energy-producing organelles inside every cell. A study published in Communications Biology, a Nature journal, found that loss of vitamin D receptor function in muscle cells directly decreases mitochondrial respiration rate and ATP production. Treating vitamin D deficiency in humans was shown to improve the maximal mitochondrial oxidative phosphorylation rate, the speed at which your mitochondria convert fuel into energy. In plain language, low vitamin D slows down your cellular engine. Correcting it to an optimal level, not just a non-deficient one, restores its speed. This is extraordinarily common after 60. Your skin's ability to produce vitamin D from sunlight decreases by approximately 50% between the age of 20 and 70. Your kidneys become less efficient at converting stored vitamin D into its active form. And if you spend less time outdoors, which most people do as they age, the gap between what your body produces and what it needs grows wider every year. Warning signs: muscle weakness, particularly difficulty rising from a low chair, or finding stairs harder than they used to be. Bone or joint aching that reliably worsens in winter or in low sunlight months. Frequent minor illnesses, low mood in autumn. And fatigue that noticeably worsens between October and March. That seasonal pattern is one of the most telling signals there is. What to ask your doctor: request your 25-hydroxyvitamin D result as a number, not just normal or fine. If it sits below 40 nanograms per milliliter, ask specifically, is this level optimal for me or merely non-deficient? That is a different question, and it deserves a different answer. What to do: 15 to 30 minutes of midday sun on your arms and legs, 3 to 4 days per week when the season allows. For food, salmon, sardines, egg yolks, and UV-exposed mushrooms are among the few meaningful dietary sources. Vitamin D3 supplementation at 2,000 to 4,000 IU daily is widely supported for adults over 60 when levels are below optimal, but always get your level tested before supplementing at higher doses. Now, the fourth cause. I have saved this one for last deliberately, because this is the cause that ties every video in this series together. Cause number 4. Mitochondrial decline driven by nutrient depletion. Your mitochondria are the energy factories inside every cell. They take the food you eat and the oxygen you breathe and convert both into ATP, the chemical currency your body runs on. After 60, mitochondrial function declines naturally. That is biology. That is real. But it is not the whole story. A 2016 study published in the journal OncoTarget took muscle biopsies from adults with a mean age of 72, some chronically exhausted, some not, and compared their mitochondrial content directly. Same age, dramatically different mitochondria. The exhausted group had significantly reduced mitochondrial content and suppressed mitochondrial regulatory proteins in their skeletal muscle, which means the difference between exhaustion and vitality after 60 is not simply about how many years you have lived. It is about what your mitochondria have to work with. And what they need to work with is 4 specific things. Coenzyme Q10, which we covered in the first video of this series, is the electron carrier your mitochondria use to generate ATP. It declines naturally with age. It is further depleted by statins. When CoQ10 runs low, the mitochondrial chain stalls. Magnesium, which we covered in our second and third videos, is required for over 300 enzymatic processes in the mitochondria, including the final step in ATP synthesis. Without it, the chain completes every step but the last. B vitamins, particularly B12, B6, and folate, are essential cofactors in the energy conversion cycle. Without them, fuel enters your cells but cannot be fully converted into energy. Iron, needed to carry oxygen in your red blood cells to the mitochondria in the first place. Without sufficient iron, the fuel delivery system breaks down before the mitochondria even begin their work. And here is what this adds up to in practice. A person over 60 who is mildly low in all 4, CoQ10, magnesium, B12, and iron, none critically low, all sitting at the bottom of their reference ranges, will feel profoundly, persistently exhausted. And their standard blood test will report, everything looks fine. I had a patient I will call Robert, 70 years old, retired architect. He described his fatigue as structural, as if the scaffolding that used to hold him up had been quietly removed, piece by piece over several years. He was still standing, but only just. His standard panel was unremarkable. But when we tested more specifically, red blood cell magnesium rather than serum, active B12, CoQ10, ferritin, every single one was at the bottom of its range. Not deficient, functionally depleted. We rebuilt his diet around what I call the mitochondrial framework, the foods that feed all four systems simultaneously. Sartines, CoQ10, omega-3 fatty acids, B12, and iron. Four systems, one food. Pumpkin seeds, magnesium and zinc. Dark leafy greens, folate, iron, and magnesium. Beef liver once a week, the single most nutrient-dense food for mitochondrial function in the human diet. B12, B6, iron, Q10, and folate in one serving. Within 8 weeks, Robert used a word he had not used in 3 years. He said, "I feel capable again, not transformed, not young again, capable," which, after 3 years of running on empty, was everything. Let me bring this together clearly before we close. 4 causes of exhaustion that are common, measurable, and correctable. Subclinical hypothyroidism. Ask for a full thyroid panel, free T3, free T4, and thyroid antibodies, not just TSH. Undiagnosed sleep apnea. Ask specifically for a sleep study referral. Home testing is now available. Functional vitamin D insufficiency. Ask for your result as a number. Ask if it is optimal, not just non-deficient. Mitochondrial nutrient depletion. Ask for ferritin, active B12, red blood cell magnesium, and CoQ10, not the standard versions of those tests. The specific ones I just named. None of these require you to accept exhaustion. All of them require you to ask for something more precise than a 12-minute appointment and a reference to your age will produce. This week, write down which of the 4 resonated most with you. Write down the specific test name. Take it to your next appointment. 1 test, 1 conversation. Helen got her lights turned back on. Robert got his scaffolding back. Your fatigue is not permanent. It is not your age. It is a signal. And now you have the language to read it. Now, one final thing, and this connects directly to what we just covered. We talked today about mitochondrial nutrient depletion, CoQ10, magnesium, B12, and iron. In my next video, I am covering the medication that impairs your body's ability to absorb 3 of those 4 nutrients simultaneously with every dose. Acid reflux medication, omeprazole, lansoprazole, pantoprazole. These drugs do not flush nutrients through your kidneys the way diuretics do. They do something more fundamental. They change the pH chemistry of your stomach, and in doing so, they dismantle the precise acidic environment your gut needs to extract B12, magnesium, and iron from the food you eat. You can eat perfectly, you can supplement carefully, and on a proton pump inhibitor, certain nutrients pass through you almost entirely unabsorbed. One of those nutrients is B12. And B12 deficiency, in its early to moderate stages, produces neurological symptoms that are clinically very difficult to distinguish from the beginning of cognitive decline. Memory gaps, mental slowing, pins and needles, fatigue that nothing touches. In some patients, it has been misattributed to dementia, and in those cases, it was reversible. If you or someone you love takes a PPI every morning, that video is not one to miss. Subscribe now. Hit the notification bell. I will see you there.